The scientific rationale for the Immatics vaccine was that there are peptides specific to renal tumor cells that are not expressed in normal cells, and that by administering these peptides with adjuvants that you can generate an anti-tumor immune response. The basis for the trial was combining that vaccine with sunitinib, which is an initial standard of care in kidney cancer and felt to have favorable immunomodulatory effects. So it really formed the basis for thinking that you could augment the anti-tumor activity of sunitinib with a vaccine. So the overall results of the IMA 901 vaccine in kidney cancer were negative. There was no survival advantage to patients getting vaccine in addition to sunitinib compared to sunitinib alone. This was mirrored in the immune responses, which were much weaker in the phase 3 study and not associated with survival. In the phase 2 experience with the vaccine, there were much stronger immune responses that were associated with survival. The reasons for this discrepancy I think are unclear. It may be that sunitinib, while having some favorable immunomodulatory effects, also has some negative immunomodulatory effects. It may just be that, as often happens from phase 2 to phase 3, with larger patient numbers, you get the more true results, the more true experience. So clearly further work needs to be done. So given the overall negative results of this phase 3, we tried to look at what would be the explanation for it. There was some evidence that there was immune suppression from sunitinib. Again, previous preclinical and some clinical data suggested a favorable immunomodulatory effect, but in this trial, while some of that was observed with reduction in myeloid-derived suppressor cells, there was also a deleterious effect on monocytes and antigen-presenting cells. So it may be that on balance there was a less favorable immune environment for the vaccine to work. Whether or not the vaccine itself can be improved with better antigens or different antigens, I don't know. That's been a struggle with vaccines in cancer for a long time, is do we have the right antigens? Do we need more? Do we need less? Do we need different ones? I think it's more about the magnitude of immune response than it is about specific antigens. The question of why there was a lesser immune response in this study and whether it was a tumor microenvironment phenomenon. Again, the immune response to tumors is complex, so I think it's hard to pinpoint exactly what was going on in this study. Again, we have peripheral blood from patients, and there'll be a lot more data coming out about the immune response in subsequent presentations and publications. What we don't have is what's happening on the tissue level. We don't have post-treatment tissue from patients in this study or in any study of this vaccine to really know what's happening at the lymph node level and at the tumor level in terms of the robustness of the antigen-specific T-cell response. In terms of toxicity, I think everything was as expected. Sunitinib has its list of toxicities. They were seen in this study. The vaccine certainly didn't alter them one way or the other. They were not better or worse, really were identical between the arms. The limitations of the study, I think, were a few. One was that it was an open-label study. Whenever you have that, you can have some bias either for or against the investigational arm. In this study, for some reason, patients on the control arm of sunitinib alone had a longer duration of treatment and longer investigator-assessed PFS. So for reasons that I don't fully understand, investigators were more comfortable leaving patients on sunitinib. It led to a greater exposure and potentially biased the results. The second would be that it's a relatively small study. Because it was HLA-A2 restricted for reasons of the vaccine and the peptide, it was a relatively small study, and of course you can get biased results when you have such a small study. In terms of the promise for vaccines, I think with the renewed interest in immunotherapy, hopefully vaccines, which have always struggled to have an anti-tumor effect, frankly, in most of oncology, can enjoy some new life. And whether or not combinations with checkpoint inhibitors or other T-cell stimulators, there are many new drugs being developed, not just checkpoint inhibitors, I think we'll see vaccines make a comeback in combination with some of those newer therapies.